Good day, everyone. Welcome to today's webinar discussion on eliminating health disparities. I am Clorinda Wally, president of Good Days, one of the nation's leading patient assistance and advocacy nonprofits. Good Days is proud to present this webinar as part of our annual chronic disease campaign. Through this campaign, our focus is to lower the number of preventable deaths caused by chronic illness and to dedicate more resources to treat and cure unpreventable conditions. Each year, we host this webinar during National Minority Health Month to hear from expert voices who can help us understand and combat the unequal health burdens that affect our country. I am thrilled to have with us today some of the leading voices who are working on the front lines of this issue. To kick off our panel discussion, please welcome to the stage Burgess Harrison, the CEO of the National Minority Health Association. The National Minority Health Association was instrumental in ensuring the establishment of offices of minority health in all 50 states. And their work continues today with a number of critical initiatives, including the Health is for Everybody campaign. Burgess, thanks for joining us for the second year in a row.
Clorinda, thank you very much for the opportunity to be here to represent the National Minority Health Association and to bring this wonderful group together to talk about how to eliminate or activities that are taking place to eliminate health disparities. With that, I'd like to let our panelists introduce themselves. So Dr. Farmer-Dixon, do you want to start?
Hello, everyone. I am Dr. Sheree Farmer-Dixon. I am Dean of the School of Dentistry at Meharry Medical College in Nashville, Tennessee.
Dr. Thompson?
Hi, everybody. My name is Dr. Sam Thompson, and I am an assistant professor of advanced pharmacy practice at Florida A&M University College of Pharmacy.
Thank you for introducing yourselves, and appreciate you taking time today to be with us on this panel. So, Dr. Farmer-Dixon, when we talk about racial health disparities, many people fail to recognize the importance or impact of oral health on the rest of the body. And it's something that I've been learning over the last couple of years as well. Would you like to just kind of speak to that and the whole movement now toward oral and medical health integration and what that means? And then, how do health disparities factor into that?
Yes, there are a lot of studies, and thank God we're now seeing that the mouth is being connected to the rest of the body because we know it physically is, and what goes in your mouth can affect what is happening in the rest of your body. And so when we think about some of the diseases that disproportionately affect vulnerable and certain racial and ethnic groups and certain populations. When we talk about diabetes, we talk about high blood pressure, cancer. Sometimes with cancer, it can be identified early in the mouth before it is detected somewhere else where you're seeing red patches or you're seeing white patches. And so we know that if you're a diabetic patient, then in some instances, the healing process, if you get a cut or get a wound, may take longer. And so looking in the mouth and seeing that they've got puffy gums or they've got buildup of plaque and calculus. In the gum, just like you have other nerves and in other parts of the body, you have nerves and blood flowing through your mouth. And so having infection in your mouth that can go through your bloodstream and transfer to other parts of the body, it can impact those individuals who do have diabetes, can impact those people who have heart disease. And we're now finding that it's associated with Alzheimer's disease. So information and knowledge is power. And so it's very important that when we're talking about health, achieving overall health, optimal health, that you have to think about the mouth, what's happening, and encourage. As I say, for healthcare professionals, I don't need to be a cardiologist. As a dentist, I can ensure that I am taking blood pressure, I'm doing the medical history, and that I'm connecting and making certain that the patient is connected to a healthcare team. And that healthcare team being, members from the medical team, whether it's a nurse practitioner, whether it's a physician, but members of the or nutritionists and
Right.
members of the oral health team as well.
So certainly get the importance of oral health now with, your overall health. So now talk about, how are health disparities impacting that from an oral health perspective, and what do we need to know, and perhaps what are things that can be done to address it?
Some of the health disparities that are associated with oral health is when we're talking about being able to have access. We know that caries is a oral health disparity, and it is one of the most preventable diseases that is highest in children, in lower socioeconomic groups, in people of color, and we see it higher in rural areas and inner city areas where they are limited to access to care. So recognizing first that oral disease in people of color, in rural and vulnerable populations is a disparity. So how do we help address that? And that is helping to improve access. And access is not just about making it available. It's covered through Medicaid, but having it as a part of Medicare and Medicare expansion so that our older adults can have affordability of care, but then leveraging and advocating for healthcare providers in those areas to take those insurances so that if you have individuals who are on Medicare, who are on Medicaid, who have a means for being able to have their services paid for, but then if they can't find a provider. So working with community organizations to make certain that individuals can navigate to find someone that can provide the dental services that they need. And so it is a team approach to addressing the oral health disparities of periodontal disease, also that's gum disease, because we say get your teeth cleaned every 6 months, but having access to be able to do that and wondering, why do I need to do that? When I smile, my teeth look fine, but there can be things that are going on underneath the gums. We call it the silent killer. The plaque and calculus can be building up, and from the outside, it looks fine, but underneath it's busy eating away at the bone around your teeth. And all of a sudden you wake up one day and your teeth are loose. And by the time you do go to the dentist, it's too late because you've lost this bone and you've got to lose those teeth. The teeth are made to last a lifetime. So helping to have a team approach that is not just having a healthcare provider in that community, that is critical, but helping the community be able to navigate to get to that person, engaging community workers in that area, community activists, because there's also the thing of trust. And just because I set up in a community does not mean that the people will come. I don't know you. Who are you? Why should I come to you? Why should I trust you? And so there has to be a relationship that is built, a rapport that is built as well. So I'm a great advocate of a team approach to addressing health disparities, and particularly oral health disparities, so that we help eliminate caries and periodontal disease and help those that do have it navigate that this can, you can get help.
Right. Thank you. Dr. Thompson, being a pharmacist, I'm not sure if you're aware, but the National Minority Health Association was launched by Dr. David Dalton, who is a PharmD. So the pharmaceutical, being pharmacies and pharmacists are near and dear to our heart, and he reminds me of it every day. So considering the role that pharmacists play, and the idea that there's pharmacists in many communities, and there's a whole discussion about that in terms of there are some pharmacy deserts and so on, but there are pharmacists and they play a role in the whole healthcare continuum as part of the team. What are your thoughts relative to pharmacists and eliminating health disparities? Where do you think a pharmacist's role is? What can they do? What's being done? What are your thoughts?
Oh, thank you for that question. I think there's a lot of things that we can do. Pharmacists are at one point in time the most trusted healthcare profession. And if you think about it, pharmacists are the first people you see if you want to see someone, you know, for hands-on care. They're changing that a little bit in pharmacies, but we get questions all the time from people, especially those who can't necessarily afford to always go to their primary care provider. Also, we're leading in vaccinations. So most of the vaccines that we're able to give to the community are from PharmDs. I think to bridge the gap of health disparities, we need to actually investigate pharmacy's role. I think there needs to be more literature out. I know the FDA is a place that loves to investigate these things, NIH as well. And I think we need more pharmacists, especially from HBCUs, to be more vocal about these health disparities. I think we need to touch on rural health even more. I think pharmacists are stepping up to the plate more and trying to bridge that gap. And we need to engage our learners as well, even more ferociously with their ability to educate. So we need to educate more about health disparities. I think a lot of people don't know what they are. And it's just the lack of, you know, health equity due to socioeconomic purposes. Sometimes there could be many things, but there's a gap in health and that access to care. And I think pharmacists need to continue providing that access. And then we also need to be collaborating with everything in education. We need to collaborate with, you know, dental schools. We need to collaborate with other disciplines so we can really try to bring an interdisciplinary approach to stopping a lot of these health disparities as well.
What I want to ask both of you is, in today's world, in my view, is we need to have better healthcare consumers. When you go in to see, whether it's your pharmacist or your doctor or PA or whatever, you have X amount of time, minutes, like singular, 3, 5, 8 minutes max. What would be your suggestion to the consumer, in particular, the marginalized, minority, hard to reach, community populations out there, to get the most out of that, 5 minutes with your healthcare provider? Because whether we like it or not, it's incumbent upon us to get our best healthcare. No one's going to be doing it for us. We would like to think that's the case, but that's not the case. So we got to be good consumers. Any suggestions, the tips, recommendations that both of you would provide from your respective areas?
Sure. One of the things that I say is that when you know that a meeting or that appointment is coming up, and so be prepared for it, get ready for it. And I parallel to it, when you're getting ready to go to work, you get ready to go to work, you get dressed. So it's kind of the same thing. And by that, I mean, go ahead and start mentally or physically writing down questions that you may have. And I'll just use a scenario: a person, you've got a toothache. So you get an emergency appointment to go. Yes, you want to have that issue addressed, but be thinking about, you don't have a dental home, asking some questions. You may have just gone through on the internet and just Google someone in your area and called and got an appointment. But do your homework. Online, you can always find out information about the person that you're going to see, number one. But more importantly, if you have health issues, how does my just basic things, what are some things that I need to be doing that I can do at home to improve my dental health or my overall health? In this case, my dental health. What else do I need to be doing beyond coming to the dentist on a regular basis? What are they? Any foods or things that I should or should not be eating? But the other thing, before when I talk about that trust, if this is somebody that you're going to the first time, it's okay to ask them about their experience, their background. If you've looked online and you can't find any information, when you go, be able to ask that information, so that you're putting your life in someone's hand, and you need to be comfortable with that. And if you're getting a full, a recommendation for a treatment, ask, are there alternatives? Do I have other options? Always ask, what are other options? There's always a plan A, but is there a plan B? And is there a plan C? And don't be afraid to ask. And if they say yes and explain it and you don't understand, it's okay to say, I don't understand. Can you explain that in another way? This is not a fake it till you make it. And sometimes we will use words that, like I said, periodontal disease. Well, everyone may not know what that is versus me saying gum disease. And so being able to ask those questions, but it is, who are you so that I can trust you? These are the concerns that I have of what's going on. What has happened to my teeth that they're getting loose? Can you explain what could I have done differently? And what do I need to do differently going forward so that you are advocating for yourself and for your family?
Dr. Thompson?
Yes, I completely agree with Dr. Farmer Dixon. But also as a pharmacist, we are responsible for accountability as well. And I think on our end, we need to be more educated in health literacy and cultural competency. Everyone doesn't speak like us. There's a lot of, when we do a lot of research to improve um, building these bridges for health literacy, one thing to answer your question is, how do we improve trust with patients? And I think sometimes we may be speaking English, but we're not speaking the same language. And it's so interesting because to build this trust, we have to sort of investigate 50 to 100 years of practices that have misaligned trust with minorities. And I think that when it comes down to what we have to do on our end to make our patient, our client more comfortable, I think we need to start investigating just from even the academic standpoint, what is the best way to connect with this patient? What is the best way to connect with their families? And then from then on, we build that trust and then we increase access to care through education. But it's like you said, how can I do that in a 5-minute visit? How can I do that in a 10-minute visit? I think additional training can be implemented. And training doesn't necessarily have to be on the job. There's other ways to train, especially when it comes to our providers. But yes, in my opinion, it's kind of a interesting crux of trying to build this trust and trying to get the patient to want the best for themselves, trusting us as providers, but we only have 10 minutes to do it. And I've got 15 patients, and then I've got to work through different third-party issues. So I think we can start building better relationships with bigger groups in our communities if we really come down to one of the biggest issues with health disparities, and this is researched, which is improving trust with our clients, and then improving patients' knowledge, and then improving providers' knowledge.
Well, one of the things that we at the National Minority Health Association launched this campaign we call Health is for Everybody, in order to begin to help do some of that. One of the things that's not happening is we're not even talking. We're not listening. Everyone's in their own silo of what they believe, and that's all that they want to hear. And unless you agree with that other person, whatever that is, then they're not even going to hear you. And so we're trying to create a national and international discussion about health, and that we do care about other people, and trust is a big part of that. But you can't trust unless you're communicating and unless you're listening to the other person in terms of what their interests, needs, desires, and whatever is impacting them. So that's why we kind of launched this campaign to begin this, again, national, and foster this national discussion around health. So from that, and we're kind of getting closer, to the end here, want to be sure that what would be for each of you, just if you could do one thing. And Dr. Thompson, I wanted to, as we talk about the time that people have, for example, to talk to their pharmacist, it's even less time actually, right, than somebody who's meeting with their doctor. Because when you're at the pharmacy, it's that retail transaction sort of, and I hope I'm not disparaging the relationship, but it's that very short, you go in to get your prescription was sent electronically, they have it, and you're going to just pick that prescription up. So now a consumer has to sort of slow down the transaction to get to ask the pharmacist some information while they're sort of checking out. Anything in particular, how do you build trust when you have such a short period of time, at I'll call it the point of sale from a retail perspective? How do you do that?
Things are very fast. I moonlight as a retail pharmacist. And every organization's different and every setting is different.
Sure.
One thing I do is little things that they don't necessarily have to teach you in these programs, which is repeating someone's name several times. Keep building an eye contact. And of course, every patient's different. Sometimes in other cultures, eye contact is a form of disrespect.
Yeah.
Either way, you have to read the room of your patients and not treat them like a number. No one wants to be treated like a number. We would like to be as personal as possible with the most professional of cadences.
Right.
So it can be kind of hard, especially when you've got a million medications to fill, you've got different personalities. Pharmacy is an exceptional way to build your own leadership skills. So, and your ability to multitask. So fitting in that patient in those 30 seconds to a minute, that's their moment. So it's more training that's needed, I believe, on both ends, but it is difficult. And I want to give just a big, warm, shout out to all of my retail pharmacists because it is extremely difficult to do that, especially right now. There is a huge issue with burnout, with mental health upon my colleagues, but we still show up every day on the front lines, willing to do whatever we can for our patients, no matter how long or short of a time that we have with them. We don't believe that you're just a quota or a number. And so hopefully that message gets spread more and more when you go to your pharmacist and you're able to truly make a commitment to trust us as much as we impact your lives.
Thank you. I appreciate that. Dr. Farmer Dixon, do you want to end with your similar thoughts?
Yes, I think people don't care about how much you know until they know how much you care. And so making certain that as a healthcare professional, as a dentist, that I'm listening to the patient, that we listen to the patient and take time. Patients can sense when you're in a rush, and so she mentioned about that eye contact and being able to know their name. In the chart, I'll just have a little area where you can make little notes, little cheats that are you going to remember every person and everything about a patient? Absolutely not. But in the electronic health record, I'll have little notes. So when I walk in, hi, Miss Jones. Well, how did your son do in that football game? Because the last time you were here, that's what, and that makes the patient at least feel like. And I really want to know. I'm not just saying that, but so that I can remember little personal things about the patient, so that you connect with them. Because if they don't trust you, or if they trust you, they're more likely to comply with what the recommendations that you make, and the treatment that you recommend. And the ultimate goal is that we want healthier patients. And so having that connectivity and that relationship and being sensitive to not making assumptions about a patient because of the way they look or their socioeconomic status or where they live, that if they've got this diseased mouth, that it's because of negligence or that they're just being trifling. And a lot is access or just not knowing and wanting to do better and so you treat each patient, as I say, as if how you would want to be treated and how you would want someone to take care of you and understand and have a level of compassion for you and empathy.
Thank you. I'm actually going to create a T-shirt that says "Treat me like I'm from zip code 90210." But, I
How
want
about one?
there you go. Well, I want to thank both of you today. We're kind of up against our time here. I want to thank the Good Days organization, and Clorinda, you and your team. Really appreciate you giving us the opportunity and this platform in which to talk about, eliminating health disparities. And the discussion is really important. If we're not talking about it, then we're not fixing it. So Thank you for being the catalyst for doing that. And Dr. Thompson and Dr. Farmer Dixon, thank you very much for your time today to talk about eliminating health disparities from your respective positions, and appreciate all the great work that you do. So keep
Thank
it
you,
up.
and thank you for the opportunity to be here and to share.
Thank you.
Thank you. Clarita?
Well, thank you so much, Burgess, and to our panelists. Eliminating health disparities is very important to this organization, and I appreciate all that you all are doing on your end to help alleviate. And as we know, it's a long road ahead, but together we can get there. So thank you all again.
Thank you.
So shortly, we will hear pre-recorded remarks from United States Representative Lucy McBath and Raul Ruiz on what they are doing in Congress to advance health equity. Before that, we have a very special live guest to bring on stage. Please join me in welcoming Dr. Eduardo Sanchez, Chief Medical Prevention Officer for the American Heart Association. Dr. Sanchez is among our nation's leading experts in eliminating health disparities. Among his many accolades, he's one of the authors of the AHA Presidential Advisory on Structural Racism and its Health Effects. Thank you for being with us today.
Thank you so much for having me. I am humbled by and am so pleased by the fact that colleagues like Mr. Harrison, Dr. Thompson, and Dr. Farmer Dixon are doing the work that they do. And I am so grateful for the invitation to participate with y'all. And Good Days, what a great name, but thank you for what you do. I'm going to get started with some slides that are meant to help you not have to look at me the whole time, and then walk us through what I think is a really, really, really important way to think about this. And that's in the framing this around possibilities. We heard from the panelists a few things that I think are really, really important. Not necessarily these words, but these are important concepts. Team-based health, trust, time, and the notion of total health. And I think some of what I talk about will resonate with the things that y'all talked about on the panel. First, disclosure. This is really just meant to say I've had the opportunity for 3 years to serve as the principal investigator of something called the National Hypertension Control Initiative, whose objective was to improve blood pressure control, eliminate disparities in blood pressure control in persons who are served in federally qualified health centers, 350 of them, in fact, around a quarter, that serve about 7.5 million people, that 350 community health centers, and again, trying to address blood pressure control in those settings. This was done in partnership with the Office of Minority Health and the Health Resources Services Administration. I want to start by looking at going back 250 years to the preamble of the Constitution and to the Declaration of Independence, which says, we hold these truths to be self-evident, that all are created equal, that they are endowed by their Creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. And I use that as a credo every single day to think about what's my mission today. And part of my mission is to help everybody achieve life, liberty, and the pursuit of happiness. I have the great privilege of working for an organization whose mission statement is to be a relentless force for a world of longer, healthier lives. I got to say, Good Days has this figured out, because Good Days aligns with that, but those are words that most people understand and can resonate with, maybe better than to be a relentless force for longer, healthier lives. So we may be stealing your name, Good Days, because that's a really good one. I want to come next to where the AHA, actually, I want to back up a second. And I've got some words that describe an aspiration, the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identification, socioeconomic status, geography, preferred language, or other factors that affect access to care and health outcomes. I'm hoping that every single person who is viewing this and will see this can resonate with that. That is a thing that we should all be aspiring to. And I would say to you, if you were wondering what that is, it is the health equity definition from the U.S. Department of Health and Human Services Center for Medicare and Medicaid Services. And I say that because the words health equity have taken on a certain amount of baggage that is not aligned with what health equity is. I'm just going to leave it there and say, let's remind people what it is that we're trying to do and not necessarily get caught up in the argument or the discussion about the words we're using to describe it. We should all be committed to it. And I'm willing to talk to anyone who wants to get to that true north, and I'll use whatever words they want if we can get to true north by talking. But we got work to do, ladies and gentlemen. We've got some work to do to achieve that place where this notion of optimal health for all, irrespective of the different variables and characteristics that define them. And this is just meant to be one example of where there are disparities. And on one side is cardiovascular disease mortality by race, ethnicity. On the other side is stroke disease mortality by race, ethnicity. And what I want you to see is that the top line across there, without going into a lot of detail, this covers a reduction in cardiovascular disease and stroke mortality over 10 years. What you can see is that there's one line that's really, really high above the others. That's the line for cardiovascular disease mortality among Black people, stroke mortality among Black people in the United States. Too high, unacceptably high compared to the others. We are not getting to equity. We are not getting to the elimination of disparities until that and other disparities that we can see by mortality and morbidity, by race, ethnicity, and lots of other categories are completely eliminated. One more depiction of this opportunity and reality of disparity is around life expectancy. During COVID, we saw a reduction in life expectancy across the board. And this graphic captures the year before COVID, the first 2 years of COVID, and what's happened in the aftermath. You can see that in every single one of the categories, there was a reduction in life expectancy, a slight increase. But what I also would like for you to look at is that the fact that these lines are at different levels means that there is disparity in life expectancy. And what we'd be hoping to do is to get all those graphs, all those life expectancies for everybody across the board at that highest level. That is when we will have achieved the elimination of health disparities. Was mentioned earlier that I had the great privilege of being part of a call to action to identify and call out structural racism as a fundamental driver of health disparities. It's really important because as we think about and as we have looked at the disparities in mortality and morbidity in the American Heart Association, of course, we realize that some of that is contributed to by disparities in the unfavorability and favorability of certain social determinants of health. But as we looked at those, we came to realize that those are influenced by certain previous historical disparities in structures, some created intentionally, that have resulted in the concentration of poverty on the one hand, that it manifests itself in disparities or in concentration of poor access to healthcare, poor access to housing, poor access to quality, high-performing schools, and disparities in access to capital, wealth. So we hear that there are families in this country, sometimes disproportionately Black, Latino, American Indian, or Alaska Native families that don't have $400 to fix a broken dishwasher, a broken car, a broken anything, and those things set people back a big, big way. In that work and in that call to action, the American Heart Association said to itself, it is not enough to do a call to action. What can we do as an organization? And I'll just leave it at, we made 10 commitments. We've done reports, progress reports on those 10 commitments, everything from trying to diversify the workforce to addressing hypertension disparities, to doing that workforce work, not only in terms of scientists and doctors, but also doing that work internally in terms of leadership at the American Heart Association. I have an 8 on my lapel, and I'm hoping that the picture of the 8 is there. It's not, but Life's Essential 8 is AHA's definition of what it takes to achieve ideal cardiovascular health: not smoking, healthy eating, physical activity, good sleep, healthy weight, healthy blood pressure, healthy blood glucose, healthy cholesterol. If you're good on those things, you are going to live a longer, healthier life and have good days. There's Life's Essential 8. There's all those things I said depicted. And again, that is a pathway to good health. What we've learned at the American Heart Association by doing some research is that when you're good on those 8, you are good on lots of other things, less likely to be have diabetes, lower severity and length of episodes of depression. You can delay or slow down cognitive decline. And quite frankly, as I looked at the list of the conditions that Good Days helps to address through patient assistance, I couldn't help but notice that there are some cancers and and osteoporosis lend themselves to preventing those things when one can adopt and be good on one of those 8. I want to be clear. It is simple to say Life's Essential 8. Sometimes it's difficult to achieve depending on some of those social determinants of health factors that are influenced by some of the structural racism issues that I talked about earlier. There's Life's Essential 8. At the top, it talks about some psychological factors that play a role. And Dr. Farmer-Dixon, I am going to try to figure out how to make sure that oral health is depicted on this Life's Essential 8, because there's alignment and yet there's opportunity for complementarity. And then at the bottom, you see social determinants of health as influencing. It is meant to depict the influence that social determinants of health have on the Life's Essential 8. So I want a new equation. And that equation is that Life's Essential 8 plus cancer screening, evidence-based cancer screening, plus vaccines, some of the other conditions can be affected by vaccines, equals good days. I'm going to change the words longer, healthier lives to good days. Coming to the end, the American Heart Association has updated the structural racism as fundamental drivers of health disparities, and now has just released a paper addressing structural racism through public policy advocacy. And I wanted to end here because this is also aligning Good Days work with AHA's work. Of course, patient assistance, really important. Of course, awareness, we are in that game. But in the game of advocacy, we are also trying to play a role. And so as I come to an end here, one is in the area of access to quality care, and are believers that Medicaid expansion everywhere possible is really, really important, and making sure that FQHCs are made even more available in more communities. In addition, I'm going to close and not cover these slides. When one looks at structural disparities, access to education is one that we should fervently address. if we could improve graduation rates of those young people who are either in low-income households or in households that are disproportionately not graduating from high school, we could get to the place where we could improve income for those persons and their families going forward. We can improve the wealth situation. They might have $1,000 to fix that broken thing, and health becomes a thing that they can have insurance to take care of, and some of the health literacy improvement that would allow them to live health promoting lives. And so I think that was the penultimate slide. And I want to leave you with my favorite quote these days. I'm not an optimist. I'm a very serious possibilist. And organizations like Good Days and the American Heart Association and the others represented by the panelists can make the difference and create the possibilities that we all were talking about today. So thank you, Clorinda, for having me. And thank you for listening.
Hello everyone, I'm Dr. Raul Ruiz, representing California's 25th Congressional District. Thank you all for being here, and thank you for your advocacy and support of the chronic disease community. I'm an emergency medicine physician, and for years I've treated patients in my home community in the Coachella Valley. Growing up in an underserved farm worker community with farm worker parents, I experienced firsthand the dire need to improve healthcare access in rural, underserved, and underrepresented communities. That is one of the main reasons I ran for Congress in the first place, and it's what I've been doing ever since. For the past decade, I've been fighting for legislation to improve access to high-quality, affordable healthcare for all patients. That includes making sure we have a robust healthcare workforce to care for patients, an increase of screenings for disease, and the development of innovative treatments and medications. Most importantly, that means working towards a more equitable healthcare system to ensure all patients have access to these treatments and screenings. We need a healthcare system that allows everyone to get the care they need and when they need it, regardless of where they live or how much money they make. No one in America should go without healthcare simply because they can't afford it. We need to target resources to the communities that need them most to ensure the most vulnerable communities are not left behind. Today, we face an obesity epidemic in our country and our community. The Hispanic community in particular faces high rates of obesity. Obesity is a chronic disease, and there are steps we can be taking to address it head on. While there are medications to help treat obesity, Medicare can't cover them under current law. That is why I co-lead a bipartisan bill that would change that, with my Republican colleagues and fellow physicians, Representative Wenstrup and Miller-Meeks, as well as Representative Gwen Moore. Our Treat and Reduce Obesity Act, or TROA, would allow Medicare coverage of anti-obesity medications. It would also allow more qualified healthcare providers to administer intensive behavioral health therapy. This is a vital step towards combating the obesity epidemic and ensure that readily available treatments get into the hands of those who need them most. In addition, many patients suffer from chronic diseases and have to jump through hoops with fail first step therapy protocols that can be dangerous and exacerbate their condition. That is why I co-lead the Safe Step Act with Representative Dr. Wenstrup, which puts the patient first by requiring insurance companies to establish an exception to medication step therapy protocols in specified cases. This would make sure patients have access to the best treatment available for them. It puts the health of patients over insurance companies' bottom line. And I will continue fighting for these life-saving, bipartisan pieces of legislation to give patients better access to the care they need to live their best lives. So thank you for what you do. Thank you for your advocacy. Thank you for improving patients' health. Thank you.
Hello, I'm Congresswoman Lucy McBath, and I represent Metro Atlanta in the United States House of Representatives. I would like to thank Clorinda Wally and the supporting organizations of Chronic Disease Day for inviting me to send my greetings. I know how deeply personal healthcare is. I myself am a 2-time breast cancer survivor and the daughter of healthcare professionals. My father was a dentist, the first Black dentist in our town, and my mother was a teaching nurse. I know that when you or someone in your family is sick, everything else vanishes. The primary focus becomes getting the care that is needed as quickly and effectively as possible. My husband, who was recently diagnosed with a rare autoimmune disease, experienced the fail first treatment process required by step therapy, and it was a very personal reminder of the importance of our work. I'm proud to lead the Safe Step Act in Congress to give patients and providers more control in finding proper treatments. As we all seek to improve care, it's important that we make improvements at all levels, including funding medical research and public health. Back in December of 2019, before COVID-19 hit our shores, I led legislation to modernize our public health data systems at the CDC and improve our epidemic preparedness. It was long-awaited funding and was signed into law as part of the Congress's pandemic relief packages. I also led a bill capping the cost of insulin at $35 a month for our seniors, lowering the cost of a prescription drug that is life-saving for so many. I am proud to say that this bill is now law. While we have a lot to celebrate, we are certainly not done. Patients' voices matter. Providers' voices matter. And we need your advocacy and your stories as we continue to push forward toward a healthier and more equitable world. It's because of all of you that our policies are changing. Thank you, and God bless.
Thank you, everyone, for tuning in and to our amazing speakers. And I just wanted to say, Dr. Sanchez, you're more than welcome to use Good Days. And for conclusion, please visit chronicdiseaseday.org to watch this entire webinar and to learn about ways to get involved in this year's campaign and the future of helping everyone with access to care. Thank you so much.